Hey, it's Rob Fitzgerald. Welcome back. Thanks for tuning in. It's going to be our quickest one yet. I could have just said, instead of common poisons, I could have said we're going to cover carbon monoxide and iron. So, quickest one. Here we go. Carbon monoxide is a colorless, odorless, tasteless poison. It's probably the most common cause of fatal poisonings as far as a toxicity goes, most commonly from fires and from suicides. It also happens in the winter when people are using space heaters and they're inefficient and they're not burning effectively and they're generating carbon monoxide. They typically complain of having headaches. Sometimes they will present to clinics complaining of symptoms of carbon monoxide and no one recognizes it until someone dies from it. So it's clearly preventable in that case. Colorless, odorless, and tasteless, people can't tell they're being poisoned. It binds really tightly to hemoglobin, so you can't transport oxygen effectively. Smokers have maybe up to 6% carbon monoxide, whereas fatalities of CO poisoning start to happen around 40%, 50, 60% of carbon monoxide saturation. Treatment is fresh air, 100% oxygen, and possibly hyperbaric oxygen. So hyperbaric oxygen is used to treat wounds. It can also be used to treat carbon monoxide poisoning. It shortens the half-life of carbon monoxide and allows oxygen to be transported again. So quick coverage of carbon monoxide. Iron. Oftentimes it's children ingesting mom's prenatal vitamins that have iron. And so kids are small, and so a couple of prenatal vitamins with iron can cause toxicity. Iron is a really toxic compound. It looks like people that have iron overdoses, it looks like they ingested like straight sodium hydroxide or something like that. It burns from the back of their esophagus throughout their whole GI tract. So it's really damages tissue when you have free iron. So when iron saturates iron binding capacity, you get toxicity. So it's also involved in suicidal ingestions, which seems like a really bad way to go. It causes a metabolic acidosis. Treatment is going to be you're going to want to try to identify, so concentrations in blood are reflective of the toxicity, and so we can monitor blood concentrations. Because of the acidosis, we're going to look at other electrolytes, liver function tests to see if it's what other kind of toxicity it's causing. And basically what you're concerned about is how much elemental iron did someone ingest on a kilogram basis. And so if they ingested 20 to 60 milligrams per kilogram, that's moderate risk. Greater than 60 milligrams per kilogram is high risk, and so they're going to need the antidote. And the antidote is deferoxamine. Deferoxamine is very effective if given appropriately. And so typically you saturate your total iron binding capacity somewhere around 350. So if the iron is less than 350 and no symptoms, so no bloody vomiting, bloody diarrhea, things like that, then they typically use supportive care. If it's greater than 300 with symptoms, then they get deferoxamine. So deferoxamine is a chelating agent, and it reduced the toxicity. It used to be about half the people that came to the ED with an iron overdose were fatal. With deferoxamine, it's been reduced to about 1%, something like that. So it is a very effective chelator and inactivator of the toxicity. So deferoxamine makes it water soluble and excretable in the urine. So thanks for tuning in.